Dr. Kiefer, ladies and gentlemen, thank you very much indeed for an absolutely marvellous day. I arrived here this afternoon and I had a tour of Dr. Kiefer's laboratory, met the zebrafish and the stem cell imaging and our future basically in Tim's hands, and that was a very exciting tour for me. And then I met some very, very smart graduate students, far, far smarter than me. And it was a pleasure to interact with you all this afternoon. I'm so grateful for that. So it's been a wonderful experience. Now, Dr. Kiefer told me not to use any big words tonight. Nothing that is more than 2 syllables, I think he said, maybe 3. So if I do say something that you don't understand, ask me to say it again. I'm happy to try and explain it. And I thought I would start at the beginning with diabetes. Diabetes is a common condition. There are 2 types, type 1 and type 2. There are actually many more types than that, but I won't overcomplicate things. But simply, patients with type 1 diabetes have an autoimmune condition where the body has attacked its own cells inside the pancreas, inside the islets of Langerhans that make insulin. And the body's immune system has destroyed them completely, and therefore the body cannot make any insulin. And the only way to stay alive long term is to have insulin injections into the skin. And there are patients with type 2 diabetes, many of whom also require insulin, but many also can be managed with different medications that help stimulate the pancreas to make more insulin. So diabetes is a very, very common condition. Every 6 seconds, 1 person dies from diabetes. 5 million deaths a year. And by 2040, 1 in 10 adults will have this condition. It's an absolutely overwhelming condition. It's the 7th leading cause of death. And the complications of diabetes are immense. The constant high blood sugar levels lead to damage in the lining of tiny blood vessels. And these occlude and fail to deliver sufficient oxygen, and there's a process called advanced glycation end products that basically destroy the end arteries in the eyes. So it leads to blindness, strokes in the brain, heart disease, shortened lifespan, amputations. And the other side effect of giving insulin to treat diabetes is that it's very hard to regulate blood sugar by injections through the skin. We can't do that in the same kind of way as your normal pancreas would do on a moment-to-moment, second-by-second basis. So as a result of that, many patients, and some more than others, face these conditions called hypoglycemia, dangerous lows in blood sugar, where the brain doesn't have sufficient glucose to function. Patients lose consciousness. And this may happen frequently, many times a day, many times per week, and it really interferes with quality of life. It means that patients often have to come to the emergency room to get glucose injections to bring them back, and it's a big challenge. And you can see here from a study done in 1993, published in the New England Journal, showing what's called the DCCT, which is the Diabetes Control and Complications Trial. And what this shows is the tighter we control the blood sugar, and the more normal we make this condition, the A1C, the more close to normal that is, the less risk patients have of damage to the eyes, but much greater risk of getting these dangerous lows in blood sugar. So it's a really tight tightrope that patients with diabetes have to face. In Canada, there is what's called an economic tsunami. Diabetes Canada put this report out a couple of years ago, and they tell us that more than 20 people are diagnosed with diabetes every hour of every day in Canada, and that the costs are astronomical. By 2020, we're going to be up here on the scale, so this is an enormous share of the population. And the costs are, in Canada, $13.8 billion will be spent on diabetes and its complications by 2020. And our healthcare system really just cannot support that. And if you put that on a global scale, $673 billion are spent annually, or 12% of the healthcare expenditure globally are spent on managing diabetes and its complications. It's a huge, huge problem. So along came insulin. Here is Sir Frederick Banting working in the laboratory. He was originally an anatomy demonstrator in London, Ontario, and he had the idea of being able to extract insulin from the pancreas by tying off the duct inside the pancreas, the pancreatic duct. He wrote this in his notebook on October the 31st on a Sunday night while he was preparing a lecture. And you can see here he couldn't spell diabetes correctly at 1:30 in the morning. and he described how he would ligate the pancreatic duct, and he would allow the pancreas basically to make more insulin that way and be able to extract more to potentially treat patients. And in a very short space of time, from this idea in 1920 to first in human trials in 1921, 1922, it was transformative. And here's a young girl dying from the ravages of diabetes. The only treatment in those days was starvation. So there was no insulin before then, and then along came insulin, and here's the same girl a year later, putting on weight, able to live normally again and having a life. So insulin is life-saving. And insulin manufacture, you can see here is a factory in 1946 making, mass-producing insulin by processing pancreases in those days, using acids and alcohol and extracting the pancreatic juices in order to prepare this, what they called originally was iletin and then subsequently called insulin. And everybody thought that was going to be the permanent cure for diabetes. And it was remarkable, and it is remarkable today, but it falls far short of a cure. So there's been a lot of progress in the management of diabetes over the course of time. Here, for example, is what's called a bionic pancreas. So a patient wears a special pump that injects insulin, and it also injects another hormone called glucagon that raises the blood sugar. And the idea here is that you can try to control the blood sugar very finely. And then you can continually monitor the blood sugar with what's called a closed-loop system, so that you can see from moment to moment how much variation there is in blood sugar. And here is the patient on this bionic pancreas. And you can see here there's still wide variations in sugar control. It's better than without the pump, but it's far, far short of normal. So here is one of these bionic pancreas pumps, or some of the new ones coming out now. The patient wears a pump on the outside. They wear a glucose monitor, and these can be Bluetooth together and can potentially close loop and adjust the insulin for what the body's needs are. But they still fall far short of what's needed. Google has been working on a contact lens to allow direct measurement of blood sugar in the fluid around the eye. This is a very early stage, but it's quite remarkable that electronics can be miniaturized to this kind of scale that could change the future potentially of monitoring patients with diabetes. So insulin is not a cure. The question is, can we do better? Here's a picture that Cole drew for me, a 12-year-old boy. Left it in my office last year, and it was a picture of me doing nothing once diabetes is cured. And I will be very happy when that day happens, because then finally I'll be able to look out of the window. Everyone talks in my office, what a wonderful view you have. I never get a chance to look up and actually look outside. So here he has on the front of Time. It really should say, Dr. Kiefer cures diabetes, and I'm sure that will...
Pretty sure it says Dr. Kiefer.
No, Dr. Kiefer cures diabetes, and I'm sure that will happen. But we'll look forward to helping you in that regard. So moving on to islet transplantation. So here's a patient with an islet transplant. This is with a continuous glucose monitor. The islet transplant's given here. You can see here really enormous swings in blood sugar. Moment to moment, day to day, dangerous swings, dangerous lows in blood sugar, dangerous highs in blood sugar. All of those secondary complications that we mentioned with damage to the blood vessels occur. Here's an islet transplant with rock-steady blood sugar control, far better, in fact, than these pumps can ever achieve from the outside. So this is what gives us optimism that some form of cell transplant in the future really is in the armamentarium for patients with diabetes. I think in the long term it won't be injections of insulin. It will be some kind of cellular process that will truly treat the disease. So here's a picture of one of the old hospitals I used to work in, and this is the Bristol Royal Infirmary in England. And I was telling Tim and the group this afternoon that I used to be paged and come here at 1 o'clock in the morning and deal with patients that were vomiting up blood and putting tubes down their throat in the middle of the night, and blind, very dismal conditions on the old Victorian wards. But this same hospital had a history with islet transplantation, and I discovered that maybe that was one of the attractions of going to Bristol and also going to Newcastle. So there was a paper published in 1894 in the British Medical Journal by Watson Williams and Harsant, a surgeon and a medical doctor, and they described a 13-year-old boy that came into the Bristol Royal Infirmary dying from the ravages of diabetes. There was no treatment in those days. It was 27 years before insulin was discovered. And they had the idea that they could take a piece of sheep's pancreas, 3 pieces actually, each the size and shape of a Brazil nut according to their report, and put it under the skin, subcutaneous implant of cells under the skin in this boy. It did seem to improve the blood sugar for 2 or 3 days, and then of course this was the first transplant, what we would call today a xenograft, and it was rapidly destroyed by the immune system, rejected, and the boy of course died from the complications of diabetes. Now here's a connection between Newcastle and Bristol and myself and islet transplantation. This is my mentor, John Farndon, who was a brilliant surgeon and researcher, and this was me working in the hospital radio station a year or 2 ago, and he lured me from the radio station to surgery and to the lab to work with him, and I think I've forgiven him now for that year he spent away in Australia. That was okay. I didn't do too badly in the end, but I didn't know it at the time. But he was a very tough mentor, and he recruited me to Bristol, got me in the surgery program, and really helped me, push me on the way. And I should add that I went into his office one day in Bristol, and he said to me, there's this opportunity come up for you to go to Edmonton, and you should go and learn, you want to learn liver transplant, you can go to Edmonton and you can follow your research with Dr. Warnock in islet transplantation. And just as I walked out of the door, he said, by the way, if you don't come back, it's okay. And I walked out the door and I thought, he's trying to get rid of me. Anyway, I haven't looked back. Maybe he hasn't. But here was another hospital I worked at with him, with John Farndon in Newcastle, and this is where I first started working as a medical student on islet cell transplantation in rats. And this is the Royal Victoria Infirmary, and I was also telling the group this afternoon that I was covering orthopedic surgery, and these days we're not allowed to cover call from Friday morning till Monday night, but those days you had no choice. And we would, Monday night, I walked out of the hospital through this front door, and this wasn't my car in those days, but I came looking for my car, and it wasn't there, and I walked around and around and around in circles, and finally it twigged on me that it's actually been stolen, and it was. But this was the Royal Victoria Infirmary, and it also has a history of islet transplantation, and this is a famous surgeon, George Gray Turner, that Dr. Warnock will remember from the famous past, but he had a colleague called Frederick Charles Pybus, and he made many innovations in surgery, and he published this in the Lancet in 1924, Notes on Suprarenal and Pancreatic Grafting. What he was doing, he took organ donors, there were no organ donors in those days, but he had somebody come in who had just recently died, and he took the pancreas out of these donors immediately, chopped them up into pieces, and again put them subcutaneously under the skin in thin slices, subcutaneously into the abdominal wall. And he said in this report, in one case, 2 grafts became infected and discharged. He describes all the complications, but there was some improvement in blood sugar, again before the patients died. And a very interesting last paragraph in that was amazingly insightful. We should go back to some of these papers sometimes. We'd learn a lot more about the future by doing so. He said, not much can be said about the principles of grafting. But it seems that until we're able to understand them, and I feel we do not understand them at present, especially the chemical factors, then we must continue to fail in such operations, although they may appear the most rational treatment for the diseases for which they're attempted. So he was talking about immune rejection, which in 1924 they knew nothing about. He knew there was some kind of chemical factor, but he hadn't really figured it out. But he was very smart. He invented a drink called Lucozade, and he found that when he was on call getting tired doing surgeries, he found this intensely heavy glucose drink, kept him going, kept patients going, and he became quite famous for this Lucozade, and there was a slogan in England in those days, Lucozade AIDS Recovery, and he was the origin of that too. So islet transplantation then really fell away along the wayside because insulin was there, it was seen as a cure, it was successful. And then along came Paul E. Lacey, a pathologist from St. Louis in Missouri, and he discovered that he could transplant islet cells from mice and transplant them into the portal vein in the liver and reverse diabetes, reverse chemical diabetes. And he also had the idea with several colleagues, including Ray Rajot, and Garth Warnock also worked on this in Edmonton, ways to manipulate those cells in the dish to try to stop them from being attacked by the immune system. And even today, I think these are ideas that we still need to think about more and struggle with and really grasp. How can we manipulate these cells in the dish to make them less susceptible to immune attack? And there's I think, great opportunities still with this kind of approach, even though it's been hard to deliver in larger animals and in patients to date. So here is before I joined the group in Edmonton, Dr. Garth Warnock and Ray Rajotte and Norman Knietemann and Eddie Ryan were carrying out the first transplants in Canada, and some of the very early patients had quite remarkable success and were able to discontinue insulin for periods of time. And even today, I think some of those patients still have some residual measurable function, which is quite phenomenal, almost 25 years later. And this is the old laboratory. This is Dr. Ray Rajotte. This is me as a very junior person standing behind Dr. Lakey watching the islets being prepared for transplant. And this was the laboratory that the FDA had to stop us using when we started our international trial. It was a remarkable laboratory in its time, but the FDA didn't like the cockroaches outside the laboratory and the dripping liquids that, how should we say, dripped on our heads outside the laboratory. And we had to build what's called a GMP facility, and we pretty much quickly learned what GMP meant. Ultra clean room facilities, 100 times cleaner than an operating room. And we had to smarten up and build that once we began our international multi-center trials with islets, and we all learned a lot from that process. So here's the pancreas being digested. It's a complex and very labor-intensive process. This process was developed largely by Dr. Camillo Ricordi, but the Edmonton group contributed a lot from this, the idea of perfusing the pancreas with enzyme to try and get the pancreas to digest itself and separate the islets away from the rest of the tissue. And here we're putting marbles, and in those days it was literally marbles, Garth, right? But then the FDA also stopped us using the marbles because they were worried about little glass fragments breaking off from the marbles, and then we had to make artificial marbles of steel with hollow cores that would have the same shaking characteristics. So here's the pancreas being distended. It's then digested in that chamber, and then eventually the cells are implanted into the liver through a very simple operation that usually doesn't require surgery, and injections through the side, where the islets then go up into the liver. When I was first involved with the islet program, there have been about 237 attempts at this across the world, and fewer than 10% of patients had complete freedom from insulin by 1 year, and the results were challenging. And we put together this protocol called the Edmonton Protocol, where we treated 7 patients with a new combination of anti-rejection drugs. And I think one of the big successes of this approach was that we kept adding sufficient islets until we had enough to titrate the patients so that they would reach a point where they didn't need insulin anymore. And you can see these are the blood sugars before the transplant, these are the blood sugars at a year, and we were able to attain tight blood sugar control in all the 7 patients that we treated, and we thought we'd done something pretty amazing at that time. And then the process moved forward. We shared the protocol with multiple centers across the world, and now there's been around 2,000 islet infusions carried out in multiple different centers. And in Canada, Dr. Warnock moved to Vancouver and opened a successful islet program here, and there's a program now in Montreal and a new one starting in Toronto. So we have a very strong Canadian presence in islet transplantation. If we look at the results from Edmonton now 18 years later, we can see that just under 70% of patients continue to make sufficient insulin, or C-peptide in this case, which is a surrogate blood test for insulin manufacture, that they can protect themselves from dangerous lows in blood sugar, and they can normalize that test called the A1C, which is how well controlled they are. And indeed, 3 of the very first 12 patients treated are still free of insulin with their original transplants 18 years later, and we've treated now 262 patients with over 600 infusions. So the islet cells go into the liver. It's a very simple technique. It's an injection through the skin. The patient is awake but sometimes sedated. This is an X-ray of the vein inside the liver called the portal vein. We simply drip the cells up into the liver. They fall in there by gravity. We give blood thinner at the time, and then we plug the tube at the end to try and minimize the risk of bleeding. And again, it's a very simple, very straightforward, usually safe procedure when it's done by an experienced radiologist. We've been trying to look at other sites for putting islets. So, for example, more recently we've been trying to test the stomach with a gastroenterologist, Dr. Gopal Sander here, where we're putting islet cells into the lining of the stomach to see if they might be able to work better than the liver. That's very early days in our clinical trials of that, but here you can see the islets are being injected directly into the lining of the stomach, and there's some experimental data to suggest that there might be an approach that could work, and here are the islet cells being injected directly into the stomach lining. We've also worked with Dr. Ricordi in Miami, and we've been transplanting islet cells into the lining inside the tummy via a minimal invasive camera approach, a laparoscopic approach. And here we simply drip the cells onto the surface of the omentum and try to get the islets to engraft in that area too. So there's many opportunities for testing other sites for islets, including this area too, which is the skin. And here we've modified the skin as a site for putting cells in by putting in a tube. And you can see here's a rubber tube in this particular case, and we left it in for 3 days. And over those 3 days you can see an intense new blood vessel formation, and the picture tells 1,000 words sometimes in research, and this was one of the pictures that led us to think this could be an alternative way to get cells to engraft under the skin. And Andrew Pepper in my lab worked very hard on this and really developed an approach where we put a simple plastic nylon tube under the skin for a period of a month. And it's like a splinter or a sliver. It causes a foreign body reaction. And when we take out the plastic tube, we're left with this rich network of new blood vessels to support a cell transplant. And at first we tested it with islet cells, and they worked really well in this site. Before, when we tested just the skin without this approach to get new blood vessels, the transplants didn't work at all. And then more recently we've tested the same kind of cells that Dr. Kiefer's working with in Vancouver. In this particular case, these are pancreatic progenitor cells. We transplanted them under the skin also in this what we call the deviceless approach, and we've been able to get the stem cells to work in a far more effective way than we have previously. And here you can see some of the transplants working beyond 500 days before we take the skin graft out, and then the blood glucose comes high again. And we can take the graft out of the body and test it on what's called a perifusion, and we can show at 500 days that the islets work very similarly with what we call first and second phase insulin release, just like human islets would. Now, this is data back in our patients out to 18 years, and here this is what we call the hypo score, and this is a measure of risk of dangerous blood sugar lows. And you can see before a transplant, the patient's average score is around 2,000. And when we do an islet transplant, it rapidly corrects that to normal or near normal, meaning that patients no longer face that risk of hypoglycemia or dangerous low. The transplant's very safe. We were worried at first about giving anti-rejection drugs to patients, thinking about the alternatives that the patient has, which is to stay on insulin. But here's data at 18 years, 94.4% of patients are alive. Nobody has died as a result of the anti-rejection drugs. There have been a few cases of what we call opportunistic infections, but they've all been treatable. And we had two patients that had this condition, a form of blood cancer, which resolved. Nobody's died from the transplant procedure or from the immunosuppression to date. And the result of this kind of data, we've been able to move our trials together with multiple centers in the United States and Europe to what's called a phase 3 trial. And we published this last year in Diabetes Care. And this is generating data that will help the FDA, the Food and Drug Administration in the United States, generate what's called a biological license. And that's important for us, for the whole field, because up to this point, all the centers, at least in the United States, had to rely on research funding to support their activity in carrying out islet transplants. And centers could no longer get research funding to support routine islet transplants. We've been very fortunate in Canada to get some support for that from the government, but in the United States that's not been possible. So a biological license will be revolutionary for the US centers. We've improved our techniques and approaches recently. We've now been using, in I think about 150 patients, we've used this antibody which removes T cells from the blood. It's called alemtuzumab. And we use more standard anti-rejection drugs that have far fewer side effects than our original Edmonton protocol approach, and these are tolerated very well. And we've used these in combination with 2 anti-inflammatory treatments that are normally used in rheumatoid arthritis or psoriasis, and by giving these together we've been able to improve our long-term outcomes quite substantially, not to 100% where we'd like to be, but the 10-year outcomes and the 5-year outcomes are much better than they were with the original Edmonton protocol. But we're still trying to refine this to make it better, to get more cells surviving, and there's lots more research to do in this area before we proceed.